going to talk about what's new with Custodiol HTK. We know cardioplegia is a very hot topic, just as ECMO is. You've seen a lot of ECMO talks, and if you go to various conferences, you'll see cardioplegia talked about significantly. I work for Essential Pharmaceuticals, so that is my disclosure. I am a perfusionist. I still practice perfusion. Essential Pharmaceuticals is a distributor of Custodiol HTK. They don't manufacture Custodiol, so I make that distinction because it's a little unclear with our company's name. People think that we actually manufacture it. We don't. So I just want to talk about Custodiol HTK. I'm going to breeze over this since we're running very late today. It's an intracellular solution. It's the opposite mechanism of action of every other cardioplegia that's available on the market. Here's what a traditional 1 liter bag of Custodiol HTK looks like. And HTK, the H in HTK is histidine. Histidine is a powerful amino buffer, and we just saw a great talk about the inflammatory response. It does a phenomenal job at abating that. Sorry, this screen keeps going blank on me, so I don't know what, can I go back? Yeah. So here's what HTK will do, the histidine will do for you. It will buffer the pH in an environment. And if you can see the top line here, this is Custodiol HTK, and this is your basic Buckberg 4-to-1 cardioplegia. And you can see that it's going to stabilize that pH in an anaerobic environment. Here's the ischemic time of 60 minutes, 120. And so this is why you can take HTK 2 hours out without having to give another dose with the traditional protocol. And typically I go over that protocol, but that protocol is listed on perfusion.com. It's not a proprietary protocol. And then the T is tryptophan. It's an amino acid. It's a membrane stabilizer. It just facilitates the ion transfer in and out of the membrane. And then the ketoglutarate is just having that energy substrate. It's available right when you take the cross clamp off. You'll have that energy source available, and it's a great nitrogen scavenger. And then we have a high concentration of mannitol, and we all know the effects of mannitol. But interestingly enough, it's purported that its greatest effect is during an ischemic insult. And when we put the cross clamp on, that's exactly what we're doing. We're creating that ischemic insult. So what a better time to have a high concentration of mannitol in a solution. And it's got that oxygen-free radical scavenging ability. So I used Custodiol HTK for many years at Temple University. We 100% every case. And here are some of the things that I saw as a clinician when I was using Custodiol. The low viscosity allows for even distribution throughout the myocardium. It has reduced potassium levels. And at the time I was using this, Del-Nido wasn't a very popular solution for adult cardioplegia. So, it was nice not to have to deal with those high potassiums. Superior buffering capacity and compared to blood. Our blood has 2 millimoles of histidine naturally occurring. This solution here has 198 millimoles of histidine. So terrific job of buffering. And there was only one recognized protocol, which was terrific. So every surgeon at our institution used the same identical protocol, and so did the perfusionist. So there was no guessing every case, what are we going to do, how much volume are we going to give, when are we going to redose. The protocol was exactly the same. And so we had the same results. And then no additives, no compounding. You just took it straight from the refrigerator, hung it, and you delivered it. It was straight crystalloid. So at Temple, we did have a fair number of emergencies. You just pull it right out of the fridge and go, and it was terrific. And it has a 1-year shelf life. So we never destroyed Custodiol HTK. Just never happened. So the cost savings of that alone was significant. And we had a cold agglutinin protocol. So, when you get those rare cases of cold agglutinin and you're using any type of strategy that employs blood, you're not going to be able to cool the myocardium. But with Custodiol HTK, when we had a cold agglutinin patient, we could cool the myocardium and protect that patient. So just getting into the meat of what we want to talk about and what's new with Custodiol, looking at long-term outcomes. That's not often studied. I said cardioplegia is often studied, often presented, but we don't really see a lot of studies that look at outcomes 1 month down, out of surgery. So that's what I want to kind of paint a picture of what some of the research that Dr. Gneiden has been doing, and I got permission to present his data here at this talk today. So he wanted to look at, first in the laboratory. At his particular institution, a high volume institution, I think they did 4,000 cardiac procedures annually, huge. He had all strategies available to him, custodial, blood cardioplegia, and del nido. And he wanted to figure out which strategy that was available to him actually produced the greatest effects long-term for his patients. So he took a look at, custodial. He took a look at blood cardioplegia. You can see it all. Plegiosol, del nido. And what he saw, interestingly enough, looking at this long-term, you can see the results, and this is for adult cardiac patients, is that, 2 hours post-test, things were pretty normal, pretty, not a whole heck of a lot of difference. But when you start getting 6 hours out, 24 hours out, 48 hours, looking at cell, viability, then you can see it really starts to make a difference here. And so, I think that was the first time that we've seen this kind of work done, looking at what's the effect of what we're doing intraoperatively long-term on our patients. And then another one, same type of test, and again, the results panned out exactly the same, where 2 hours, not much difference, 6 hours starting to see some difference, but a day out of the culture, and look at the outliers. Oops, I'm sorry. Look at the outliers. I mean, significantly better results utilizing Custodiol HTK, and that's the histidine. That's what we're seeing there. And then neonatal. This is why del nido was formulated for pediatrics, and the results here show it. 24, 48 hours, the neonatal cells were just as viable with the del nido as they were with the custodial. But when you go backwards and look at the adults didn't do so well. They're different cells at that point. And so this bears out that it's a great solution for pediatrics, developed for pediatrics, and maybe, I'm not saying it is or isn't, but maybe it's not as good as what it is for the pediatric population. So after he validated in the lab which one in his mind he thought was a better solution, he wanted to take a look at it in the actual clinical setting. And so he put out a study looking at long-term protection, taking a look at high-risk coronary patients, and basically looking at 100 in each arm of a del nido, HTK, and blood cardioplegia. This is 4-to-1 blood cardioplegia, and this is 1-to-4 del nido, so the original del nido formulary. And delivering them, the del nido and the HTK, at the exact same rates, exact same intervals, to make it as uniform as possible. Obviously, the blood cardioplegia, he had to give, a little more frequently just because the nature of the solution. And here, none of the patients had any statistical differences between the patients. But here's one of the interesting finds out of this particular study, and this is looking at interleukin-6 levels. And the first column was the baseline, and the second one was immediately coming off cardiopulmonary bypass. He measured blood at the coronary sinus, direct coronary sinus measurement. And you can see there is some slight variability with the del nido group compared to the HTK and blood cardioplegia group. And you can see the outlier was, very much higher. And then looking at syndicin-1 levels, same blood measured, and we know that high syndicin-1 levels indicate a deterioration of the glycocalyx. So that means the glycocalyx is starting to break down. And again, oops, I'm sorry. I keep wanting to use the laser. Right after we come off bypass, you can see those levels rise significantly. And then I guess this is how it translated out in actually looking at the clinical outcomes. And the thing that stuck out to me, even though it's not highly significant, clinically significant, is the atrial fibrillation. We had 8 patients in this arm, and 4 of them converted to permanent AFib. We had 4 over here, and none of them converted to permanent AFib. And we know how expensive treating AFib is. I think a recent article I saw is around $12,000, $13,000 just to treat AFib postoperatively, so pretty expensive. And the ICU stay is a little bit higher, and length of stay is a little bit less. So those are the numbers that stuck out to me. And then this one was just looking at all kinds of episodes of any kind of rhythm issues. And again, we see the atrial fibrillation is the one that sticks out to me, is having 10 of those 19 converting to permanent AFib. And then this was a 1-month follow-up of all these patients, which was very interesting. You don't see the 1-month follow-ups on studies that are out there. I don't see very many of them, but the atrial fibrillation in the Delnito group, again, and the tachycardia higher. And I think that speaks to the protection, long-term protection of Custodiol HTK. And there's his conclusion. And the problem with, the Delnito cardioplegia in this first particular study is that there was the thought that maybe you could go 90 minutes with Delnito. And so I think that created some of the variability here, but he has since changed that to 60 minutes. So then the next evolution of the logical steps is, okay, these are single dose techniques. And again, looking at 90 minutes for the Delnito group and thinking, yeah, this is probably a little too high, but does redosing cardioplegia have any ill effects on patients? And so basically, he put out a similar study, and there you go. And he used the same type of study arms that he did in the previous study. But just looking at the single dose techniques available, the Delnito versus Custodiol HTK. And what's you can see he bolded it in red, redosing Delnito cardioplegia had significant issues with postoperative afibrillation. Definitely higher interleukin-6 levels, definitely higher syndecin-1 levels when redosing as compared to just giving one single dose. So redosing cardioplegia does not come without some risk, as we can see right here. And here's some of the, like I said, the IL-6s. Look at the redosing group. Again, much higher than the initial dose of cardioplegia. Actually, in both groups, even the Custodiol was a little bit higher in redosing. So redosing definitely does not come without its risks. Same thing plays out here with the syndecin-1 levels. Redosing obviously elevated those as well. So we think that, giving extra cardioplegia and giving an extra dose is going to create some increase of osmotic pressure, and that could translate to some of the issues that we're seeing. So then COVID hits right in the middle of all this research, and at his particular institution, just like everybody else, beds were scarce, patients were on ventilators, and so he kind of wanted to reimagine what he was doing in his with his techniques to try and optimize patient throughput, to minimize the amount of time that patients were on ventilators and recover in the ICU. So what he decided to do was take a look at how he delivers Custodiol HTK. And he decided that in trying to expedite these patients, most of his cross-clamp times were less than 60 minutes. And traditionally with Custodiol HTK, you can often give, in the traditional arm, you could give up to 2 liters in the initial dose. Since his cross-clamp times were 60 minutes or less typically, he decided to take a look at half that dose, taking a look at utilizing just 1 liter of Custodiol HTK for cross-clamp times of an expected less than 60 minutes. And so just wanted to make sure that it was safe. He already had a study arm well in place and got clearance to do so. And this was the dosing technique that he gave, and again, 4 to 8 degrees centigrade, up to 1 liter, and then subsequent doses, he would give half of that. And of note here, and I didn't, all of his patients received retrograde in this fashion, so he'd give 2/3 antigrade, 1/3 retrograde for this low dose protocol arm. And it yielded pretty good results, very similar to the results that he was seeing in the previous studies. And this bears out in the data here. And again, he did compare to all the modalities he had available and just gave 1 liter of del-nido cardioplegia. And again, the interleukin-6 levels played out again a little higher in the del-nido arm. So he concluded that this was a safe and effective way to try and minimize the amount of time in surgery and try and optimize patient throughput. And then from there, I provided feedback because I'm going all across the country. I'm looking at what all institutions, what they do, what their feedback is. And one of the things that we talked about was, how about modified custodial? There's modified del-nido, and there's not a lot of studies that can do direct comparison to modified custodial. Here's the protocol for it, giving it just 1 to 4. So 1 part blood, 4 parts crystalloid HTK, delivering it similarly as he did with a low dose protocol. And again, why even consider modifying a solution that's working so well? Direct comparison. Now we can actually do apples to apples comparison of original del-nido. We can do prospective data and finally get some, good studies out there that aren't just retrospective data. So very important to get that out there. Here's some of the early data and work from this. A paper is going to come out in Sage probably August to September, looking at all of the data. But one of the feedbacks, and even another reason to consider modified, is that if you've ever used 100% crystalloid, as you push all of the blood through this coronary system, it can bleach out the heart and give that, almost white effect. And it can sometimes make it difficult to trace the targets. And so with that little bit of blood in there, that makes those targets just pop. And so typically in the early phase, he's just using this for CABG surgery right now. So if he's doing valves, he'll stick with the original clear crystalloid low protocol. But if he's got a CABG patient, he'll use this new modified protocol.